afternoon from Dr. Sai to everyone. Hope you have enjoyed our lectures on health and wellness series. This is the number 5. There will be a question and answer session after the presentation. Please forward and comment on Facebook or YouTube live stream. It gives me immense pleasure to introduce Dr. Sanjeev Suratwala, who is a board-certified orthopedic surgeon specializing in comprehensive treatment of spinal disorders. He is an assistant professor of orthopedic surgery at the Donald and Barbara Zucker School of Medicine at Harvard, mentoring medical students interested in orthopedic surgery. After medical school at the Columbia University College of Physicians and Surgeons and residency training at the New York Orthopedic Hospital, Dr. Suratwala went for additional training in spinal surgery from After fellowship training, Dr. Suratwala was awarded a prestigious travel fellowship for the service of
Just to show both YouTube and
worked with renowned spinal surgeons in France, Germany, and Switzerland. To broaden his experience, he has also volunteered at hospitals in India, providing care to underprivileged patients. Dr. Suratwala has presented research at international meetings of the American Association of Orthopedic Surgeons, the Scoliosis Research Society, the European Spine Society, and the Association of Spine Surgeons of India. He has published numerous peer-reviewed articles in prestigious journals, such as the Journal of Bone and Joint Surgery and Spine. Dr. Suratwala has been recognized by his medical peers and awarded the Castle Connolly Top Doctor Award for New York Metro Region multiple times. Dr. Suratwala has been a devotee at our Hindu temple for almost 30 years. Without further delay, dear friends, I present to you the spine surgeon, Dr. Sanjeev Suratwala.
basic bodily sensation induced by a noxious or painful stimulus. Is typically felt by a nerve and is characterized by physical discomfort and typically leading to evasive action. So people don't like pain. And either if it's an acute or short pain, or if something that's chronic or longer term, both of those can be disruptive to the patient and their lifestyle. And very often people come to a physician, especially a spine surgeon, with pain complaints. Hips, knees, hands, shoulders. The spine is also not spared. Very often when people have knee arthritis or hip arthritis, they may also have arthritis of the spine, and maybe in the lower back, it may be in the neck. And the definition really of arthritis is inflammation of a joint. So anytime you have two bones close together or almost contacting each other, there's cartilage that cushions the surfaces and allows the bones to move smoothly. Smooth surface starts wearing out over time with injury, with age, or other traumatic events, or even inflammatory conditions. The bones can start rubbing against each other, and that can be very painful. So that's arthritis. And here's a schematic on the right. You can see where up at the top, these normal thick discs, you can see there's a space between the bones. And as you go further down, the space is worn out. The bones start looking irregular. And that's just because the bones rubbing against each other. And again, this is another drawing showing you the same idea where the cartilage starts wearing out and the bones start getting closer together and become irregular. Sciatica, here's another common term that people come in with. I have sciatica, I have sciatic pain. Sciatic nerve is actually a specific nerve that goes along the back of your leg. And it's actually, if you look at your thumb, it's typically as big as your thumb. So it's a very big nerve. And as you can imagine, it's formed of a lot of little nerves. So when you have conditions of spine, the little nerves that come together and become the sciatic nerve can become irritated, and then you can get pain along the sciatic nerve, and that gives you sciatica. So when people talk about sciatica, they're really talking about pain along a nerve, typically on the back of their legs. Common spinal problems, pain. As I mentioned earlier, it's one of the most common conditions that we see as orthopedists and spine professionals. You can have it in the neck, you can have it in the back, you can have arm pain, leg pain. The other thing that we see occasionally is deformity or curvatures of the spine. So this is scoliosis. You can look at the person with the back and you can see there's a little spine. Or kyphosis when you look down at the back. And kyphosis is something that may be related to poor posture, age-related conditions, fractures, etc. And that's typically, we might see it in an elderly patient as they start hunching over. So these are common complaints of patients of ours. The other things people come in with is neurologic deficits. They may have weakness, numbness of the arms or legs, or pain along their arms or legs. So that's trying to get medical attention for back pain, which is the topic of the day. And there's a lot of reasons you can get back pain. Just because that back pain, they get referred to a spine surgeon, but you have to realize that not all back pain comes from the spine, and there can be stress-related irritants, muscle spasms, back sprains, ruptured disc, wear and tear arthritis. Those are the typical things that we see with spine things. We can also have miscellaneous causes, which can be quite significant and important to look at, including problems with your bowels or the back, and you might see a spine surgeon for it, but in fact, you might see somebody else. So get a proper exam, get a proper history, examine the person, and get a sense of where exactly the pain is coming. And here's another, just a description can come from, including mechanical causes, which is fractures, sprain, which is partial tearing of the muscles, the ligaments. But you could have infections, have tumors, kidney disease. So as I mentioned, there's a lot of different reasons for back pain. And as a physician, you always have to think and have this in the back of your mind, like what could be causing the back pain. So why is it important? It's one of the most common conditions that people present with. It's only second to the upper respiratory infections as a cause of physician visit. So a lot of patients go to the doctor because of back pain. And up to 2/3 of the population, typically the adult population, will have low back pain at some point. So again, extremely common. Back pain is much more common than radiculopathy, which is pain along the legs, or sciatica. But as you can, the U.S. people will have some back pain at some point in their life. Limited or more something that's more recurrent, more chronic, and and nothing's wrong, they go to a physician. But the good news for the vast majority of people is that if you have back pain, other things that go with it,
recording in progress.
Sometimes emotional stresses can play a role in back pain. And if you have a job that involves prolonged sitting, standing, etc., we've all been through this pandemic over the past 2 years. So there's been a change in people's personal exercise habits, work habits, and I've seen an increasing correlation with back pain as well, people coming into the office. Mechanical back pain. So if we just focus on spine-related conditions, it can be multifactorial. So it could be from the bones, it could be from the muscles around the bones, it could be from tendons, ligaments, it could be from stretching, tearing, or contusion. So if you worked out, I sometimes see people go to the exercise room and they overdo it and they come in with back pain. In the winter months here in New York, you're shoveling snow. Sometimes people stress their back and come in with back pain as a result of muscle spasms. And and this is important because trying to figure out where the pain is coming from will help us guide the treatment. So you want to treat the right thing with the right treatments. Disc degeneration, people come in and they'll say, "Well, I got this X-ray and the report says I have disc degeneration." It's normal. It's just a part of aging or wear and tear of the spine. Is dehydration of disc, and it could be aggravated. So the good news here is that if you see on the X-ray, here's a bone. It says L3. There's another bone L4. There's a gap in between them. That's where the disc would be. And those discs look normal, but if you look at where the red arrow is pointing, you can see that the bones are almost touching each other. So this is a more extreme example of what would happen with disc degeneration, where the disc just wears out and the bones start getting closer together. And this is what it would potentially look like. On the left is a sort of cadaver specimen of the staining, and here's on the right is the MRI, and you can see a piece of disc protruding out. So this disc degeneration can be a condition that results from a disc herniation or disc-related injuries, and it can be a cumulative event. So you could have multiple injuries to the same disc, and over time it can end up causing disc degeneration and more chronic back pain. Reasons for pain going down into the legs or sciatica, it's most typically seen with the pinched nerve that we would like to describe it. So a nerve is being irritated by something. It could be a piece of bone where there's a bone spur or arthritis. It could be a bulging disc that's putting pressure on the nerve. That's something that I see very often. It could be from a piece of bone from a fracture. If you have a fracture and a piece of bone goes out of place and can end up irritating a nerve. It could be from bleeding, infection, or tumors. So there can be several reasons for pain going down the legs. Usually that's from an irritated nerve. And here's, again, a list of systemic conditions that can give you back pain. The top of the list is cancer. It's from the Cleveland Clinic Foundation. And that's people think about the worst. Like people come in and say, "I have back pain. I'm concerned about cancer." So, the odds are that it's unlikely, extremely unlikely to be cancer. But that's one reason people come to see me is like, "Oh, I heard I had a friend who had cancer and I'm just concerned about it. I want to get checked out." And it's not contagious and you're not going to get it from your friend, but it's on the list of differentials, but it's extremely unlikely. And we look at the whole picture before we look into this as a cancer or some other explanation for back pain. So the diagnosing reasons for low back pain is important because, as I mentioned, there's so many different reasons that people come in with back pain, and help trying to figure out what it is extremely helpful. The x-rays may be of limited value and may not show appropriate pathology like a disc herniation. You really need to get an MRI for that, but it is helpful to look at the alignment of the spine, the bone quality, the bone appearance, the gaps between the bones, etc. Especially if you had a fall or a traumatic event, or if you're an older person who just comes in with back pain, or there's some other reason why you're suspecting, the x-rays can be very helpful as a very first step in looking at back pain. And here you can see on the left is a more, there's one bone that looks brighter than the other. So we're always looking for symmetry and of the spine. Everything should look similar. If there's one thing that looks different, you want to investigate a little bit further. On the right, you can see the bones look different up here above the arrows and where the arrows are. So those are signs of fractures. So that's something we pick up on x-rays. The MRI is superior to a CAT scan. So a CT scan, a lot of people look at getting a CT scan for their back pain. But if you're looking at the soft tissues of disc or the nerves, the MRI is far superior to it. So if you've had back pain for more than 6 to 7 weeks, if you have some injury along your nerves where you can't move your arm, or if it's numb or weak, if you had a traumatic event, if there's infection or a cancer concern, then the MRI would be something we would get in addition to an x-ray. Obviously, this is something these days we have to go through insurance for, but we do recommend MRI in these scenarios. The CAT scan, CT scan is useful for evaluating bony structures and tumors and fractures. So here you can see what the spine looks like, and again, spot the difference. If you look at the picture of the spine, you can see all the bones look very similar, except this one here, which is very different from the others. And it's a traumatic injury, and there's actually a dislocation or misalignment of the spine as a result of the fracture. Testing for nerves, it can be helpful if somebody comes in with nerve pain, numbness, tingling, or weakness, or if somebody had surgery and have new symptoms or different symptoms. So we will occasionally do nerve tests. We'll send you off to a neurologist or other specialists who might be doing these nerve tests, and some of you may have already had these. And it can be uncomfortable, painful. You may not feel it very much. It really does depend on the person and the person doing the test. But it can be helpful to figuring out where somebody's nerve pain may be coming from. Like, for example, carpal tunnel. It could be for a pinched nerve in the neck or a pinched nerve in the wrist. And sometimes these nerve tests are very helpful in figuring out where it's coming from. So once you've kind of gotten a sense from the patient, you've done a proper history, you've tried to get a story from the patient, you've done an exam, you've maybe done some tests, x-ray and MRI, a lot of the treatment is focused on what your ultimate diagnosis is. And if there is a recent injury or some underlying medical condition, somebody's older, they have osteoporosis, then we get a lot more aggressive in doing some of these tests and treatments. If it's somebody younger and they've just had symptoms for a few days or a couple of weeks, we're much more conservative about treatment. We don't get too aggressive with treatments. But again, if somebody has an acute neurologic dysfunction, that's the most concerning thing. Typically, somebody comes in and they can't move their leg, or they feel numb, they can't feel their leg, or can't feel their hand. That would be something that would require more urgent evaluation. So how do you manage somebody who comes in with acute low back pain? Obviously, I mentioned the slide earlier with Google.com. You go in there, you put in back pain, and there's more than 4 billion search results. So you can certainly self-diagnose and self-treat it. And as I mentioned earlier, the vast majority of people get better on their own, regardless of what you do for it. So it can be helpful to just relax and do the basic conservative treatments. But occasionally it can be disabling and can limit your life because of extreme pain. So typically without any neurologic signs, should be signs, not symptoms, sorry, you go for a conservative treatment, modify your activities, you try and figure out what caused the pain in the first place and try and not do that. Bed rest can be counterproductive. So, those of who grew up in India, a lot of times you get prescribed bed rest. That's typically not something we like to prescribe for back pain here. We like to keep people moving, but in a controlled way. Bed rest can be counterproductive. It slows down the recovery, and it can be helpful if it's a severe disabling pain, but again, for the longer term, it's not recommended. And the first thing I usually recommend is taking an anti-inflammatory, something like an Aleve, Advil, etc. NSAIDs, those can be helpful over the counter. Muscle relaxants, those are typically prescription medicines, can also be helpful if you're having a lot of muscle spasms. We typically don't prescribe narcotic medications like oxycodone, tramadol, Percocet, Vicodin, etc. PT, chiropractic care, again, very common. You can provide some small short-term benefit, but there may be an expense, especially with co-payments, etc. And some people want to be careful with their budgets, or they may not have the means to go for these treatments. So just be aware that they can be helpful for short term. So again, if you did absolutely nothing and took maybe an Aleve or an Advil, the odds are you'll just get better on your own. here's just a schematic of what things look like with the brace. So the left is without a brace, and people tend to slouch. And there's hydrostatic pressures inside your pelvis with the fluids and bowel contents. And you can see on the right, when you put the brace, you kind of really take the stress away from the spine. So I find bracing quite helpful. And this is a very, very old slide. I think it was made like in the 70s or 80s from my fellowship days. And I like it, so I still use it because it kind of demonstrates very easily what the spine looks like without the brace and with brace. And for back pain, I am a big fan of recommending bracing for short-term use. Posture, again, these are common sense things. This is bad, don't bend like this. This is good, just smiling. So try and, if you have to bend down, just use the spine alignment, bend with your hips and knees as they all tell you, don't bend with your back. So if you have an acute episode of severe back pain, as I said, use a brace, maybe use an Aleve or an Advil, take it easy, try and avoid doing things that cause the pain in the first place. So you want to take it easy and not rush off to physical therapy as well. Sometimes those manipulations or overexertion can irritate and aggravate your pain and make it last longer. So I usually recommend resting, but not bed rest for the first week or two until you start feeling better. And then you start increasing activity as you tolerate. And that may be a good time to start physical therapy if you really want to. So if you look at the natural history of what happens to people with back pain, it can occur in cycles. So it can vary in frequency and severity. So if you look at it, you can see the blue line is just time. And the yellow line tells you at the top is more pain, the bottom is less pain. And the goal when people have the severe pain is to rest, decrease your activities, take some medications. And as you go down and your pain starts getting better, that's when you start exercising. But you may have another episode of pain, and then you do the same thing again, and then you have less pain, and then you keep doing the exercise again. And you can see how with this exercise program, you can actually stretch out your remission or pain-free episode. And the goal is to reduce the peaks or the heights of severe pain that you get. So if you are consistent with it and you keep with your activities and exercise as recommended by your physician or with your physical therapist, and you do your own exercise, over the long term, you will actually reduce the severity of your pain and also the frequency, how often you get the pain. And this is just essentially saying what the previous slide showed. So it may almost be normal or common to have low back pain. If 2/3 of the population gets it at some point, I guess I would consider it a normal part of living. And it's a self-limiting symptom. It's really not a disease per se. And the peak incidence is 35 to 55. Those are your most active years. And the good news is as you get older, some of these pain episodes do decrease, these acute back pain episodes. And there's a published literature. If you look over time, at the bottom is the age. The solid line is the X-ray evidence of degeneration, and the broken line, the dashed line, shows you the back pain episodes. You can see there's a peak between 30 and 50. There's a peak of back pain, and then as you get older, the back pain, actually the severity and frequency does go down. But your X-rays keep getting worse. So the X-ray is never going to get better. Over time, it's going to keep getting worse. And the point here is that even if your X-rays show disc degeneration, multiple levels of arthritis, etc., you'll look at the report and say, oh my God, this is terrible. You can see here that the pain actually doesn't correlate with what the X-ray is showing. So just because you have a report that shows multiple herniation, multiple levels of disc degeneration, doesn't mean you're going to have chronic low back pain or always be in pain. And the severity of pain also does not correlate with the amount of disc degeneration. So I've seen cases of people with every single disc is worn out, it's bone on bone, and they have absolutely no pain. And I'll see patients who have very little degeneration on X-ray, and they have the worst pain they can imagine. So again, there's really no correlation with pain and the X-ray or the MRI we get for our patients. This is another lesser symptom that I'll see patients with, but this is essentially the sciatic or pain down the legs. Some people can exercise in the gym or lift something and have a severe pain down the legs or numbness, and they'll see me for this. And again, typically we would do conservative treatment, so it would be the same treatment, maybe use a brace, take the medications, the anti-inflammatories, etc. If it gets better on its own, you really don't have to do anything. But if something that stays persistent, say 2 to 4 weeks or longer, or if it's actually getting worse day to day, week to week, that's when you would see a medical professional for. And there can be spontaneous recovery even with symptoms. And if there is there's a higher risk of progressive neurologic deficit, residual deficit, depending on how long symptoms linger. So on the right, you can see there's a disc protrusion here at the bottom of the spine, and that can irritate the nerves, which are the black lines behind disc, and you can have pain down the leg. So if there is something with a deficit, so if you have weakness of your foot, ankle, toes, legs, whatever, then the MRI is appropriate. And very often we might see a disc herniation or neural compression. So that's when we would talk about modifying activities, medications, again, same thing, anti-inflammatories. We might use steroid pills for this. Physical therapy, massages, mobilization may be helpful. And here, if there is a deficit, so if there is some weakness or severe numbness, that's when you would actually consider more aggressive treatments, because these can end up becoming more long-term or permanent neurologic deficits. So we get more aggressive when somebody comes in with neurologic symptoms versus back pain symptoms. And then eventually some people may have, rather than an acute episode, like just waking up with pain and pain for a week or two, you may have pain that lingers for more than a month or two. And this is something that lasts for more than 6 weeks. And this is where we would get x-rays and MRIs, make sure there's no other reason other than the spine. And this is where physical therapy, potentially surgery, may be helpful. I'm a big fan of recommending things like yoga or Pilates. Those who have access to a pool, water-based exercise programs can be very helpful. Electric current therapy, the injections, people a lot of times will go for injections, facet injections, epidural injections, really have not much benefit for somebody with chronic low back pain. So injections like these epidurals people talk about, they're much better for pain down the legs or sciatica rather than low back pain. And so you've gone through the cycle of history, physical exam, diagnostic testing, maybe some treatment options. Here's some healthy lifestyle choices. And again, these are common sense, very intuitive, but sometimes people just like to hear it again. So I looked into this. I tried to look up some research and seeing what correlates with back pain and recovery. So this is something that comes up all the time: smoking and low back pain. There's a very definite, strong correlation with smoking and low back pain. And it's not necessarily just the smoke per se, it's the nicotine in it that can contribute to low back pain. So if you're vaping or doing the Nicorette chews or whatever else you might be doing, or the patches, nicotine itself can be contributing to low back pain and disc degeneration. So if you are somebody who's smoking or using nicotine products, quit. That's one of the best things you can do for yourself, for your health, not just for your overall health, as Dr. Sai might attest. Parts of the body, including your lungs, but it will actually help your back as well. And here's a study. This is older, but they looked at a meta-analysis, which is a review of a lot of literature, a lot of published studies, and putting them all together in one place. And their conclusions: both current and former smokers have higher prevalence and incidence of low back pain than never smokers. The association is fairly modest, and it's stronger in adolescents than adults. So again, you don't want to start smoking ever, especially if you're a teenager or a younger person, because that will lead to higher episodes of back pain. Again, on the right, I can attest to the food and the temple. So I'm always a big fan of those foods. And on the left, questionable. Again, these are lifestyle choices you have control over. Nobody's telling you what to eat, what not to eat. And these are simple changes that you can make to your lifestyle that can have a big impact over the long term. Here's something that the U.S. government put out, the U.S. Drug Administration, for the steps to a healthy lifestyle. And it actually includes food, different food groups. And this looks different. You might have seen other versions of this, the food pyramid in the past, but they've actually made this three-dimensional and included more of the grains, vegetables, fruits, to highlight the importance of that in your diet and the less importance in the meats and beans. You really do need the proteins. And I know I may be speaking to a vegetarian audience, but certainly your food choices can be important. And here in this diagram, they've actually included the exercise. You see the steps here. So that's an important component to the healthy lifestyle. So not just your diet, but exercise and activity also plays a big role in a healthier lifestyle. And this brings me to the weight and low back pain. People ask me this all the time. Is there any correlation? So overweight, obesity increases the risk of low back pain, and people who are overweight or obese have the strongest association with seeking care for low and acute and chronic low back pain. So yes, there is a correlation. it may or may not necessarily cause your low back pain, but people who are overweight or obese tend to have more frequent episodes of back pain, more severe episodes of low back pain, and pain that doesn't go away as quickly as other people. So it's important to factor this in as well. So when you're looking at healthy lifestyle choices, along with your smoking and the diet and the exercise, the weight can play a significant role. And this is based on a lot of literature out correlating back pain with weight. And again, just something similar, another study. And then the formal exercise program. People always ask, so should I exercise? How should I exercise? So even simple exercise that you can do, including aerobic activity, movement instructions. So for the senior citizens here, a lot of gyms have this silver sneaker program. You may have seen people doing Tai Chi, just gentle motion stretches, postural exercise. They can be extremely beneficial for you, including not only balance and preventing you from falling and injuring yourself, but also stretching out your spine and working on your core to help the muscles around your spine. So I wanted to end here. I hope this was a quick overview of common condition of the spine and some of the treatments that we think of as physicians taking care of spinal conditions. But I want you to leave you with some messages here, which is, again, back pain is extremely common. At least 80% of the population will have back pain at least once in their lifetime. There is abundant access to free information. I did that Google example. You might want to do it on your own. Just type in back pain and see what kind of results you get. So you have to be really mindful of the source where you're getting your information from. And the treatments for back pain continue to evolve. So I mentioned something, again, most of you might know this, very basic, very cursory, but people don't do it. It's very hard to practice some of these things. So I want you to make this a part of your active lifestyle, starting today, starting tomorrow. Watch what you eat, watch what you do during the day, and get an exercise program, activity program into your daily life. And if all else fails and you do end up trying to need medical attention or care, consult a spinal surgeon, or there may be other physicians as well. You'll see chiropractors, physical therapists, rehab physicians, your primary care doctors. Ultimately, find somebody that you can trust, and they can tailor the treatment to your specific condition. So I'll end here, and I'll open up the floor to any question and answers that might be in the audience. Thank you so much for your time.
Thank you, Dr. Suratwala. That was really very useful information on such a common condition. I was not aware that it's second common condition next to upper respiratory tract infection. That's amazing, because yes, every other person you talk to has a back problem. So very enlightening. Thank you so much for that information. I do have several questions. I think I tried to group them together so we don't spend too much time. Let us see here. Most important question, what I would think that everyone thinks about, is the timing of surgery or any intervention for chronic back pain. They've gone to already the primary care physicians, a chiropractor, they've tried everything else. They've shopped around, how it is, and had 2 or 3 different opinions. From your judgment, what is the exact time? Of course, it depends on the underlying disease, but this is for the common man to understand. Yeah. When does surgery have a real changing role to modify their pain?
Yeah, so you start off with one of the most controversial questions, topics in spine surgery. As a surgeon, we get asked this a lot, and the way I look at every person is, even though I'm a surgeon, I try to avoid surgery as much as possible. So I try to be extremely conservative, and spine surgery is really not right for the vast majority of patients unless you have very specific conditions. So for spine surgery, for somebody with chronic low back pain, yes, if you've tried treatments for more than, say, 6 months or even longer, and if it's something that's affecting your life, where it's making your day-to-day activities difficult, if it's affecting your job, your work, and you've identified a specific explanation for your pain that matches the exam, the x-rays, the MRI, and you can say, I have like one disc that's worn out, yeah, then that would be somebody who's a reasonable candidate to consider spinal surgery. If you have somebody who's had back pain for, say, 10 years, and all their spine shows arthritis, there's disc degeneration, multiple levels, and you're looking at a much more extensive problem, then even with spine surgery, the results may not be to your satisfaction. So it's very important to get the right expectations of spine surgery, what it can do for you and what it cannot do for you. If you have traumatic injuries, fractures, etc., or if you have spinal stenosis, or if you have instability of the spine, those are conditions that can benefit from surgery. If you have chronic low back pain from disc degeneration, from arthritis, etc., you really have to be very selective about who would be a good candidate. And you really have to have honest conversation with your physician about what you want to achieve after your surgery and make sure that whatever you have in mind is in line with what the surgeon is telling you. Because, people come and say, well, I used to run a marathon and I can't do it anymore and I want to run a marathon again. And you look at their spine and they have like 5 levels of disc degeneration, severe stenosis, and I say, well, maybe you should think about walking instead of running a marathon. So you have to tailor people's expectations and make sure that they understand that surgery may not be a cure-all for everything, but it can be helpful in some scenarios.
Thank you. So talking about cure for, you think that there'll be some magic after the surgical procedure. In my practice, I've seen repeat surgical procedures and after chronic back pain, the pain is not relieved. We know some of the causes, spine is one organ. So what would you suggest for persistent pain after surgery?
Well, again, it goes down to trying to figure out why they have pain. So
Yes.
if it was surgery done for one level surgery for like 5 levels of arthritis or problems, then it's probably not going to work out well. And then you may want to say, well, now we have to fix 5 levels of your spine. So you have to change completely the expectation of that person. And the more surgery you do, the results do get worse. So if you have 1 or 2 areas of problems, the results are maybe more than 90-95% successful. Meeting patients' expectations, no complication, everything goes well. The more levels of surgery you do, the bigger the surgery you start doing, the success rate starts going down just from the surgical standpoint. And then if you add in the patient expectation, it goes down even more. So I don't have necessarily one hard and fast answer for somebody who's had surgery and it didn't work out or met their expectation. Yeah, if there's a problem with the implantation, if there's a problem with the instrumentation, if something is loose, if something didn't heal properly, if there's a problem right next to where they had the surgery and they had one problem that got fixed and now they have another problem that needs fixed, yeah, there could be selective cases of where more surgery could be a problem to fix a specific issue. But for people with chronic low back pain, we work as a team, interdisciplinary approach. So sometimes surgery may not be the right answer. And then you work with rehab physicians, pain management specialists, physical therapists, chiropractors to help modulate pain. So it's more about pain management at this point rather than necessarily fixing or curing pain.
I like that approach, the multidisciplinary approach, but I haven't found the neurosurgeons working with the rehab teams and neurologists. So that would be a nice approach, I think, and then when time comes for surgery, then you can intervene. So I have some common questions. So for older folks with multiple joint problems like osteoarthritis of hips and knees, does increase the back problem. So they don't know where the pain is coming from and the x-rays were like inconclusive. Any suggestion of, I actually had a patient, the orthopedic surgeon said, no, listen, fix your hip and your back pain will go away. And he was in worse pain after the hip surgery. So any comments on that?
Yeah, so I'm a trained in orthopedic surgery and I specialize in spine surgery. So I totally understand what you're saying. And I see this all the time. I'll have patients come in with a shoulder problem. They say it's coming from the neck. I'll evaluate them and say, no, it's not your neck, it's your shoulder. Same thing with the spine. You have a spine problem, it's coming from your hip, or the hip problem's coming from the spine. And really, it really is a judgment and clinical skills. You have to listen to the patient. You really have to examine the person, try and get a sense of where the pain is coming from. And occasionally it's maybe 50% from the spine and 50% from the hip. Once you get into a certain age, you might have arthritis in multiple joints. And you have to try and really hone down on where you think the pain is coming from primarily. And occasionally I'll do a selective injection. So I'll inject their knee or their hip and say, okay, how much relief did you get with that? I might do an injection in the spine. How much relief did you get with that? So patients kind of know going in how much relief they might expect from an intervention. And they say, well, I got the hip injection. I'm like 20% better. I still have severe back pain. Then you know that the spine may be more of an issue for that particular patient. You fix that. And people have tried to do literature studies on, the timing of surgery. Do you do the spine first or the hip first? A lot of times you end up doing the spine first, but I usually tell people to get their hip done first. So, it really depends on the
hip first.
what their evaluation is. And I will examine every single person myself, and I'll tell them, listen, I think it's your hip. Maybe you should do this, or we're not sure. Let's try an injection first to try and pinpoint where you might get the most utility.
And so for older folks, there was a question about any special advice for types of braces, or do you use muscle relaxant? Because the older population is more prone to kind of a history of falls and things like that, a muscle relaxant or something for pain. Some people like to give Valium, which is out of fashion now. So what's your suggestion on the braces? I thought you said the braces could be quite useful.
Yeah, so nothing, so I'll start with the first one, the bracing, nothing specific. I don't have like a brand or a specific thing that I would recommend. I do recommend supportive braces. So not to endorse one online vendor versus another, but if you go online and search for a back brace, you'll find something in the $20, $30 range that has some plastic in it that gives you some stability and structure to the spine, and support to the brace itself. And then you have the Velcro tabs that make it adjust. The most important thing is to make sure it's comfortable for you. It fits you appropriately, so it's not too loose or too tight for you. And it's supported by itself. You don't want to wear like a cloth brace, like a binder, which really doesn't give you that much support. So you want something that has some plastic in it to give it some rigidity. The cost really doesn't matter. The brand doesn't really matter. Just find something that you feel comfortable with. And I recommend that for short-term use. So you wake up one morning have severe pain, a brace can be helpful. Over the long term, it actually can be counterproductive because your muscles actually can atrophy, weaken with use of the brace, and that will cause more back pain down the road. So you actually want to focus on strengthening your spine muscles and stretching them. So the braces are meant for very short-term use. The other question about the falls and the muscle relaxant, that's a great one because I'm a big proponent of falls prevention. As an orthopedic surgeon, I see an elderly population, and I'll see people falling down and broken their hips or shoulders or hands, or wrists. So physical therapy can be quite helpful for fall prevention. Things like Tai Chi, etc., exercises, yoga, work on your balance, work on falls prevention. That can be one of the most important interventions you can do in this population. Muscle relaxants, you're right. I do prescribe Valium after surgical procedures for short term, but not in the elderly population. I will use some muscle relaxants, but again, with the caveat that, try and use it at the end of the day where you're not going to be moving around all day or when you're going to be sleeping. So at the end of the day, so you don't walk around the house and fall down. So yeah, there's always a risk of falling with these muscle relaxants, and everything is tailored. You give people 20, 30 pills so you can try it out, see how it is, whether they like it or not, how they tolerate it, how it's affecting them. And if they're too sedated with it or there's a risk of falling, you're right, it's not a good option or choice for that patient as a muscle relaxant.
Good practical points.
Yeah. Valium, I will prescribe.
I think that,
but again, very selective patients.
That's quite helpful. Yeah, so another person from the audience says, I have sciatica and my right shoulder pain all day. I let it down, says, I can't sit or stand more than 10 minutes. I guess they forget the spine is one organ from the neck to the tailbone. So they mixed up with the shoulder pain and the sciatic pain.
Well, yeah. So I'm not sure how old this person is, but based on the shoulder pain, you could have shoulder pain as a separate condition. Obviously, you want to have one diagnosis that explains everything, but occasionally, when you get into arthritis, you may have knee pain, you may have hip pain, you may have shoulder pain. And the same thing, I'll maybe inject the shoulder and see if that's relieving their shoulder pain. Sciatica, you probably, at this point, you should be seeing somebody for it. If it's affecting you to the point where you can't sit, stand, and it's affecting you day in, day out, there are medications, there's oral steroids that you can prescribe or take for it. There's injections, including epidurals, which can be quite helpful for sciatica. So I mentioned earlier that the epidurals are not great for back pain, but if you have sciatica, they actually can be very helpful. And I do epidurals myself as well. So I know from my experience that it can be very helpful for a patient. Now, occasionally, if it's so bad that the epidurals or nothing else is helpful, then surgery actually becomes a reasonable option for somebody like that.
And I know you mentioned something about nicotine and back pain. That was, not such common knowledge. And every day, day in and day out, like you said, for cardiac issues, we keep talking, don't smoke, don't drink, and the risk factors. So any relation, there was a question to secondary smoking and low back pain. Of course, it's the effect of nicotine, obviously, but.
Yeah, again, it depends. So maybe you should get a secondary smoking person to quit. It's easier said than done, and there's a lot of aids for that. But obviously, you want to limit exposure to smoking, especially if you're younger. There's long-term issues with chronic smoke inhalation, even if it's secondhand smoke. I don't think there's a lot of studies looking specifically at secondhand smoke and back pain. It's more specific to the person themselves, because the more nicotine you really get into your body, that's really where the causation is. If you're a secondhand smoker, especially in the era of social distancing, I think it may be okay.
I don't know if I missed it, Dr. Suratwala. What is the underlying pathophysiology or etiology for this nicotine and back pain connection?
Yeah, I think the presumed theory is on vasoconstriction and the effect of nicotine on kind of constricting all the small blood vessels that go into the spine.
To the region.
Yeah, to the region, especially cartilage or the disc is poorly vascularized, so there's not a lot of blood flowing to that area already. And if you cut off whatever blood is going to it, if there's an injury, it doesn't heal well or fast enough or appropriately, and you can end up with this chronic injury that just doesn't heal and end up with degeneration.
Now, this is very interesting because I hear a lot from my patients. Like you said, you found more than millions of information on the internet when they just go into back pain. Nowadays, they believe that they have to go by what the TV tells you or what's on the internet is more useful than what your doctor tells you. So I have a few patients that come back and tell me the CBD oil has helped them more than anything else. They tried all kinds of Motrin and meloxicam, you name it, they've had it. It bothered their stomach and actually did not take care of the back pain. So we're talking about medical management now. What do you think is the role of this CBD oil? They have roll-ons, they have ointment. Some of them are taking under the tongue like drops of oil. So do you really think it's helping? At least the patients believe that there is relief of pain.
Yeah, so I'm not sure there's a component of placebo effect. There haven't been any large-scale trials looking at CBD oil specifically for back pain, but I'm actually a big proponent of that. I do recommend that.
That's interesting.
Yeah, I don't, in New York State, like there is medical marijuana that's available, medical CBD that's available. There's dispensaries that will give you the drops and other forms of the CBD. Sometimes it's mixed with this THC. So I work with pain management specialists specifically on that. So if somebody is a candidate who's failed at a lot of different things and some have stomach issues with the NSAIDs or they get dizziness or sedation with the muscle relaxants, they've tried injection, nothing works, and they're not a good candidate for surgery or they don't want to have surgery, I do recommend the CBD and I do recommend pain management evaluation. Again, it may not be right for you. So for every person that says it's worked really well for them, I meet somebody who it hasn't helped. So it really is user dependent and some people get more benefit from it than others. And I'm for it. I'm strongly against opiates. So tramadol, oxycodone, Vicodin, Percocet. I think we have enough medical evidence that there can be significant side effects and harm to patients from using those, especially for back pain. CBD doesn't seem to have the same side effect profile or risk profile as those opiates. So in my experience, I think I do recommend it for patients to try and see how it goes for them.
Wow, that's interesting. Any difference in treatment for patients in India? You did quickly comment on that. How does it differ, back pain treatment in India versus here? Because the pathology is the same.
Yeah, I actually was in a conference once in India, and it was very interesting to hear the local perspective of a spine surgeon. And they said, here we have, the internet and your medical doctor, and maybe your physical therapist or a family friend will give you insights. There, along with that, you have the religious figures and the local seers and the guy down the street or multiple quacks. So there's a whole plethora of treatment options there that people go. They'll try Ayurvedic things. They'll try homeopathic things. Those are things that are not very common here, but very common in India. So they'll try the gamut of things, and ultimately, some people believe in allopathic medicine and others don't. But the treatment principles are pretty much the same. So if you believe in Western medicine or allopathic medicine and based on evidence-based medicine, et cetera, then whatever I talked about today is completely applicable to anybody in the world. It's just a lot of it depends on your belief system and what's available to you.
A great answer. So I have seen, being in cardiology, the distant disease, like so-called metastatic, not really cancer, of course, if somebody has prostate cancer, lung cancer, we look for bone mets. We've often missed vegetation, going from a valvular vegetation, going to the spine, and we never think of doing an MRI or a CAT scan. And recently we found an abscess, from an infected valve. But is there, I would say, to think more commonly as a source from an infected point of view, or something from somewhere coming around to the spine? And
yes.
Actually it was in that, yeah, go ahead.
No, go ahead, you can finish what you were saying.
Yeah, the patient did come in with cardiac guina, they had surgery. We didn't know if it was the surgery that really, the introduction of the infection came from that or the vegetation. So it was a little complex case. But just to comment on the spread of infected material to the spine. How often do you see, I see that physicians don't think so commonly about distant infected material coming to the spine.
Yeah, that's where the history and the physical exam becomes really important. I know it's becoming a lost art these days, and people don't really listen to the patient or do proper exam. But and sometimes the patients don't share that information either, so it can be difficult. But that's where you start and say, okay, is there any potential source of pain? Because as I said, back pain is extremely common and it's self-limiting. So we do get red flags, as we like to call them in spine, where if somebody has fevers, or if they have weight loss, unexplained weight loss, or night pain, or other just pain that's out of character to it, we do look for secondary sources, including infection. We look at metastases. Obviously, fevers, blood cultures, all that could be. But anytime somebody comes in with acute back pain that is not normal, and that's not a typical presentation, that doesn't sound like what they should have, we're always getting an MRI. We're always looking for a source. So I will, just personally, if anybody is over the age of 60 and they come into my office and all of a sudden they have severe back pain, I will try and find a source. So they may have an occult fracture, they may have an infection, they may have metastatic lesion, and I will investigate it till I find the source. Because there's a certain age where young people, like children, less than say 10 or 12, really shouldn't have back pain. And then the older people over 60 or 70, if it's not the typical back pain, you really always have to look for the source.
Do we still see POTS disease?
I don't.
I know it's so uncommon.
India, yes.
You said you do travel to India, so I was wondering.
Yes, but the medication I've changed, definitely the management of POTS disease. I actually just published a paper on POTS disease, TB mets to the spine and the base of the skull, and it's amazing how much destruction can happen before people actually show up with pain or any symptoms. So it's still out there in India.
Still out there, yeah. Not as common. Yeah. And I know during the COVID, everybody was in front of the computer and Zoom, everyone, So were there a lot more patients seeing you for back pains and asking you for some special chairs and equipment?
Yes.
At work. And does that help? Sitting in a comfortable chair obviously can help. Do you have any suggestion for the so-called work furniture?
Yeah, so I at the start of the talk, I had this slide for the 45-minute attention span. And I think I take that personally. So when I'm seeing patients, I'm always standing. I never really sit. So I'm getting 7+ hours, 8 hours of standing time in my office all day. And surgeries, obviously, we're standing. So I do recommend movement and activity and change of position. So very often people, especially with disc degeneration or disc problems, they cannot sit for an extended period. So it's helpful to maybe set a timer on your desk to remind you every 45 minutes or an hour to get up and stretch, walk around. It's good for your eyes as well. Take a break from the screen, walk around, just get the circulation going, take some pressure off your spine, because people will tell me that, and I know from experience that the more mobile, the more move around, you're less likely to have back pain episodes. So prolonged standing, prolonged sitting can be an issue. So sits to stand or the adjustable desks, or just getting up and walking around every 45 minutes to an hour can help. So we're coming on the 57-minute mark, so I should make a mental note to myself to get up and stretch.
Great. So I know you haven't mentioned on scoliosis. Any quick thoughts on, how to treat or when to intervene? Not the milder forms, but a lot of our young people, and commonly, I think they don't want to see the surgeon because they think it's a very complex, complicated surgery for scoliosis. Can you shed some light on that, doctor?
Yeah. So scoliosis is such a broad topic. It's a topic in itself that could be maybe another hour-long talk. In terms of scoliosis, just like back pain, you want to get to the
coming out.
Yeah, we want to do a whole lot.
I'm sorry. Scoliosis it depends on the age, the type of scoliosis. So occasionally we'll operate on very young children and kids because of congenital problems. They're born with some spinal deformity that needs surgical intervention. If you're a teenager with scoliosis, very often we'll see that in a teenage girl as they go through that growth spurt. You might get scoliosis. We'll treat them with braces. Scoliosis is really a measurement of numbers. So it's a curve. We measure it as an angle, and there are specific parameters for treatment. So if it's over a 45-degree curve, that's when we start thinking about surgical intervention, even the younger person versus the older patient as well. So it's really about measuring the curve and seeing the progression of the curve. If it's changing fast or if it's really not changing, that will determine your surgical intervention or non-surgical treatments.
Thank you. We have a few more minutes, so I'll just another 3 to 5 minutes. Do you believe in epidural injection? You said there's a limited role for pain management, but yet you see there's so many pain clinics that flourish, and the patients love to go to pain clinics rather than come to the surgeon, and delayed the process and cause more damage. I've seen it a lot. What do you think about these pain clinics?
I mentioned in my talk that the pain injections, the epidural injections, are not really helpful as much for chronic low back pain. So if you look at the insurance guidelines, the reimbursement guidelines, they'll always ask what the diagnosis is for the procedure. And if you put in chronic low back pain, they'll necessarily not approve the epidural steroid injection because the evidence is that it really doesn't help. Having said that, I do injections myself for people with stenosis and pain down the leg. So it can be very helpful for nerve type pain. So prevent the person that asked earlier about the sciatica and trouble walking around, they can be, they can find epidurals very helpful. So if you have arm pain from a bulging disc pinched nerve, lower back pain from stenosis, pinched nerves, that's the idea for doing injections. But there's other kinds of injections. When you go, so I don't want to put down a whole practice, but people will do facet injections, they'll do ablations. There's all different kinds of interventions just besides the epidural steroid injections. There's different injections that can be done. For chronic back pain, we have these pain stimulators that people put in, dorsal column stimulators, etc., pain pumps. So there's a lot of different options. So I don't want to put everybody in the same category of epidural steroid injections, but you have to try it for yourself and make sure that it's for the right reason. And I wouldn't keep doing them over and over. So after the first 1 or 2, you have a pretty good idea if it's actually helping you or not. So if it doesn't last for more than 3 months or 6 months or a year, there's really no point of repeating the epidural injection. So my limit personally is 2 at the most. I'll do maybe 3. But if it doesn't really help them that much or doesn't last, that's really the wrong treatment for them.
I think they should have guidelines for the pain clinics, not to give more than 3 injections, which would help. I just have a couple of quick questions related to asanas. Does sitting in Vajrasana, I guess you know what the Vajrasana is? You go on your knees completely flat with the heels under your gluteal regions.
Yeah.
And you sit tight, pull your stomach in, yeah? And I don't know if that is good for your digestion and stuff like that, but I don't know how much that can help. Somebody asked for that particular posture. Does it help for back? And to add to that question, any other asanas, some people may not guide you appropriately. Does it hurt these back problems? Or what are the postures or the yoga asanas that would really help you in relieving your pain?
So I'll translate into the non-yoga performing audience.
Yes.
I think the the stretches that we find helpful are, the posture you mentioned can be very helpful. You really want to make sure that your spine is in alignment, and you want to focus on stretching your hamstrings, your quads, etc. So the lower extremity stretches and pelvic stretches are very important. So if you go to any physical therapist, they will start you off with leg stretches, pelvic stretches. And a lot of that is derived from yoga, and even Pilates, a lot of it is derived from yoga. So it all takes its root
Yes.
from yoga. And you have to find somebody that is attuned and is aware of back pain and back conditions. You don't want to go somebody that's just doing it and puts you through a whole high intensity, very fast paced workout. It has to be tailored to your pace. Just the breathing posture, the lotus position that people will do, that can be very helpful because you're stretching your legs, you really have your spine alignment, you're doing breathing exercises. It can be helpful to do the deep breathing exercises to stretch out your diaphragm, stretch out your lung, and really helps you realign your spine. So being mindful of how you sit all day and you starting the day with some stretches of your legs and your pelvis is very helpful. I don't want to get into the specific different asanas in yoga, but I think if you look at the fundamentals and the reasons why you're doing it, if you just focus on your posture, the alignment, and focus on light stretches, not the high intensity, high impact ones, but just controlled stretches, that's something that can be helpful. I don't recommend a lot of significant back bends and et cetera, because that can certainly put a lot of stress on the spine. So just do things gently, as much as you can tolerate. Don't force things. A little bit of soreness and ache is okay. Pain is not. So you don't want to push yourself to the point where you're getting pain.
For that matter, even in therapy, I think some people kind of get a little more aggressive. The therapist, and they come back with worse pain. So I tell them to kind of stop it, and not go back until the pain is relieved. It does make sense. There's a new trend of vaping. Does it have any effects? This is a question that came up from the audience.
So again, I'm not a fan of any of these products to begin with. Vaping, I guess it depends what you vape, but nicotine in all forms is bad. So if you're vaping nicotine as a way of quitting smoking, fine. If the long-term goal is to quit smoking and quit nicotine completely, but I wouldn't recommend you just pick up vaping for the sake of vaping. It's really not something I recommend or endorse.
Thank you so much, Doctor. I must say, Dr. Maisokar was supposed to join us, but she had an urgent assignment, or she had to leave for a few minutes. So on behalf of the Hindu Temple Society, we sincerely appreciate and thank you for the presentation, Dr. Suratwala. And I think we loved your presentation on the spine disorders. You made it quite clear, and the areas of debatable options, I think, to my mind, was very informative, and I think it really is useful to treat patients. We wish you success and prosperity and excellent health, and we hope you continue to come to the Ganesha Temple and seek his blessings for a very long time. Thank you, Dr. Suratwala.
Thank you.